Time now for this week's Health Matters. Paul Critz with you, along with physician assistant Lynn Szabo. And Lynn, this week we're continuing a discussion we began last week, just sort of examining the barriers to access, barriers to care that we experience, I think, generally in our nation, but specifically here in Del Norte as well. There's a special sort of cadre.
Absolutely.
So let's continue that conversation. What's happening this week?
Last week we focused on KFUG ally. And today I'm focusing on referrals because I think these are a huge problem here, especially the concept of primary care as a gatekeeper. Mm-hmm. Now, when HMO started, like maybe 25 years ago, this sounded kind of like a good idea. Like maybe somebody thought they needed a referral to a specialist, and what they really needed was just to focus their primary care provider on it. And what it morphed into is a reason to say no, I guess, by the insurance companies.
Wow. Okay. Initially, with kind of the health management that was a thing a generation ago, right. Were people being referred too much? Were they being referred in instances where maybe they just needed a deeper dive with their PCP? Is that what you're saying?
I think that did happen, mm-hmm. but I don't think it happened as much as maybe was thought by the insurance companies.
Gotcha.
And so now it's just another stop toward definitive care where somebody can say no, or there can be a time delay, or I think the hope might be that the person doesn't go on to more expensive care with more expensive testing. Because it happens not only with referrals to specialty providers, but also orders to have kind of the more expensive exams done, like an MRI. Mm-hmm. And I don't think people understand that it's not up to the provider's medical judgment, that the provider is following a recipe set down by the insurance company by people who have no medical expertise.
Right.
So,
okay, let's break it down. How does this work?
So what it really means in rural healthcare, because it always means something slightly different, is an unnecessary step that adds delay before somebody can get to definitive care. So that added delay sometimes causes diagnoses to be missed, mm-hmm. or to be much worse by the time somebody gets around to getting properly diagnosed. So here's what I mean is, so if somebody wants an MRI for their knee, somebody has a knee injury, and they're used to watching sports on TV or talking to their friends, maybe it's a younger person who's kind of athletic, and it seems like an MRI is the right test to go for, and that you can get it at the drop of a hat.
I see what you're saying. Because it's like when Steph Curry tweaks his knee, he can get an MRI back in the locker room.
Oh, yeah.
Right.
But
not you and me.
No. And so there's a specific recipe, I would call it, that the primary care provider has to go through in order to get an MRI. And what that specifically is for Chef to get an X-ray, and X-rays aren't the preferred imaging for knees. Mm-hmm. An MRI is magnetic, not radiation. And also, it's like if you were looking at a knee, like you slice bread. Like if you sliced a leg, here's the slice, the first slice.
Yeah, the cross sections that it's
right,
built
instead
from.
of anterior to posterior and lateral or medial.
Mm-hmm,
okay,
mm-hmm.
So X-rays not only have radiation, but not the best way to look at like knees and spines and things like that. And then the next barrier to care, and this is a doozy up here, is that you have to go to physical therapy. So there is a limited number of physical therapy practices in this county.
Okay, I
can
get you.
only think of two right now.
Mm-hmm.
They're heavily impacted.
Mm-hmm.
It takes a long time to get in to see them, but you have to do like a series of 6 weeks of visits. Okay, so this is a person hobbling around maybe in a knee immobilizer or on crutches or something.
Mm-hmm.
That's a lot to go through before you even have a definitive diagnosis.
Right.
So, like one patient just looked at me and blinked and said, "But what if that's the exact wrong thing to do?"
Yeah, and you have to wait 6 weeks to see if you've made your condition worse.
Right. And MRIs are hugely expensive. I've seen bills for like $8,000 for people who are uninsured, and I think they're negotiated down to more like $3,000. And then there's also a line for the machine. So this is like this endless barrier to care. And I think what insurance companies are hoping is that somebody will get better, and they won't need it, or they will accept the problem and just learn to deal with it.
Do you really think it's that nefarious? Like they're really hoping for attrition?
Yeah.
Wow.
Absolutely, yeah. Yeah.
Well, okay.
And then I also think maybe they won't be insured by this insurance company in 3 months or something.
Right.
So kicking the can down the road, super common.
That's horrible.
It's horrible. And then, but they're really nefarious about it because oftentimes a young man who gets a knee injury and is, somewhat athletic and, has a little bit of education will know that they need an MRI, and they'll go to the ER demanding an MRI, and the ER can order the MRI, but the young man's going to end up paying for it. See, that's what they don't understand. And then oftentimes they get their mom involved. I don't know why, but moms can yell, I guess. And then they call the insurance company. The insurance company says, "Oh, yeah, sure, the doctors can order an emergent MRI." But they don't say the rest of the sentence.
Which you'll have to pay for.
You'll have to pay for. And so then we spend a lot of time getting yelled at by angry moms. But, the other thing, too, is here's another example. I just referred somebody to dermatology to have an atypical mole biopsied, and her referral was declined because it was felt that I could do that as a family practice PA, which I can. The first problem is we don't have the right kind of lidocaine to do that biopsy. There's a national shortage. We could have made do, but this woman was really pain averse, and so we just needed what we needed. But anyway, she decided to go to the dermatologist and private pay for it. And he actually found 4 diagnoses that I wasn't even aware of, she hadn't brought up. And 2 of them were significant rule out, got biopsies. He had the right stuff in his office, and we're ruling out significant malignancies. So not only did she got more than what she initially thought she was going in for, but now I think she should present that bill to her insurance company, because this is...
And say,
this was way more immense than the block they put.
This could have resulted in her death. Right? I mean, if something...
So they look at it, they're making financial decisions, not ethical or moral decisions.
Sure.
And it could have resulted in like a really, really big... expensive diagnoses for her, not to mention what it did to her personally.
Yeah.
Okay. So
that's traumatizing to be put through all of that disregard and that, oh my God.
Yeah, she didn't even realize it until I got her kind of worked up in the exam room. I said, well, gosh, it was good you decided to go. And this demonstrates why this was so much a bigger question than the people who were making the decision not to send you had education to recognize.
Right.
So what happens in both the community clinics is I write a referral for specialty care, and sometimes it's a slam dunk. A kid who's broken a bone goes into ortho. Really, the only problem with that right now is there's no ortho currently in Delmark County. But what happens to that, sometimes that's really quick. And sometimes I write a referral like this woman had with a skin lesion, and it goes to a very wonderful, nice group of people who are not medically educated, and they put it together the best they can by reading the notes and stuff, which oftentimes are super brief.
Sure, you're in a hurry.
And they're also in our medical jargon. So somebody who doesn't clearly understand all of the intricacies of that would definitely miss major points. And they make a decision, and sometimes they refer people for problems like if I say, look, this is an ear problem, this person has to go to audiology, then they'll send them to ENT because that's your nose and throat. And so they show up at ENT, and their office is like, what?
Who are these people that you're talking about?
It's a layer of gatekeepers that are not medical people, but
Right.
are insurance specialists.
Okay, and they work for the insurance companies? Is that
No,
the
they
next?
work for the clinics.
Is it like the patient services department?
No, it's different.
Okay.
It's a referrals clerk.
Okay.
And so, they are really, really nice people with a really, really terrible job.
Why do they have anything to say over medical decisions that
But what
you
they're
have
doing
made?
is kind of what we call a wallet biopsy.
Oh God.
Yeah.
Okay, let's
Yeah,
let's
it's an
just say,
awful thing.
yeah, what is a wallet biopsy?
Wallet biopsy is what's a patient's particular insurance, and how are they going to pay for it, and is it worth my while to take care of them?
And then if it's not worth the while financially, they go, okay, we're not going to do this referral. That person, regardless of their medical realities, is just left to hang
And
because of a monetary decision. It's a
Here's the
financial
thing that's
decision.
really difficult is that remember we talked about feedback loops last week? That feedback loop is left undone.
Sure.
So the patient, what it looks like to the patient is I never got a word, so the provider must not have done their job and done the referral.
Because you're the face of that feedback loop to them.
Right,
Yeah.
and they come back kind of angry or perplexed or what's the next step or forgotten. I had a friend actually who had an abnormal colonoscopy, was supposed to be referred for another one, in a couple of years, and that just like dropped off the face of the earth.
Oh my God.
So things that get forgotten are not necessarily forgotten. There's a financial decision that's made, and there's no feedback loop.
Wow.
And yeah, it's really awful.
I want to build through your notes and do this, but I have big questions that are just
we'll
looming
keep
up.
going.
Okay. Especially in light of the discussion we had last week with the specific case of the friend of KFUG. But okay, all right.
So so in summary, I write the referral. It goes to somebody to decide who's not medically educated, but insurance educated. I don't care about insurance, I care about doing the right thing for the patient. And then the referral kind of morphs depending on financial considerations, sometimes gets dropped and never really addressed again. And
How can it morph?
the way it can morph is, this sounds like an ear thing. They're going to ear, nose,
Oh,
and
for
throat.
that, yeah, just
And
as you walked us through.
no.
Okay.
It was an audiologist. I didn't make a mistake on that. It was an audiologist.
Right.
Or for example, it can morph if I want an MRI of somebody's brain and they try and get a CT scan. I don't like CT scans. 1 in 100 CT scans that I order is going to result in somebody getting cancer. It's not as good of a test, and it's a lot of radiation. So I know what I want for the reasons I want it, and somebody who is not medically educated is not going to get the finer points of that.
And the stricture on your time, because the notes you're talking about, the notes that you provide with the referral, with somebody's chart, with whatever, those are the notes you sit down at the computer, right, when you have the time and do the notes in. And when do you typically do?
I always do my charting on the same day, so it's fresh in my memory. It's the most accurate I can make it.
Right. And so you sit there and in how much would you say percentage of your work day is spent charting?
Sometimes it's up to a third. So about 35% of my day. And oftentimes it's after the end of the day. And, some places that I've worked don't really reimburse for that time.
Oh, geez.
And that makes providers not do such a good job on it. And some people like UHS right now is really careful to reimburse for that time.
That seems important.
Yeah, and it is important for another reason. Like when I was working at Redwood Urgent Care, the bill gets dropped as soon as I sign my name to it. Then it goes to a billing person, and the bills go out to the insurance company electronically, within minutes.
Regardless of whether or not anything has occurred? I don't understand.
No, if somebody has a visit and I chart, let's say I chart on my lunch hour, and I sign the bill, then it goes to billing, like at Redwood Urgent Care, would go to he had an offshore billing system, and that person would send the bills out to the insurance company like right away.
Okay.
So that's like within 15 minutes, at half an hour or something.
Very
like that.
efficient in that regard.
Yes. Super good feedback loops.
Yeah. Yeah. Wow.
Yeah.
Wow.
So the other problem is that if a specialist, they're highly educated, they're certainly proud of what they do for the community. And I'm talking about people in Northwestern California, not just Del Norte. And if they get too many referrals that seem wrong, they blame the provider and they stop taking referrals from that provider.
Oh, wow.
And then it gets worse. Okay. So oftentimes, because say there's no rheumatology up here, there's no endocrinologist, people get referred from here to UCSF. And UCSF right now, rheumatology is refusing referrals unless the referral comes from the local rheumatologist.
Okay, did they define what a local rheumatologist for somebody in Del Norte or Humboldt would be?
In San Francisco, that's the one that's 3 blocks down,
Sure,
right?
sure,
And here
exactly.
it's maybe Reading, maybe.
But do they consider that person because it's the closest? Is that still local then in their estimation?
No, they don't even think of it. It's completely off the radar.
Yeah, yeah.
It's like our whole fire scene and no power scene and all that. It's like anybody south of Ukiah probably, or no, I would say south of the Del Norte line was going, huh?
Yeah.
Same deal.
Yeah.
So I tried to get somebody to a specialist in a really specific kind of dermatologic problem. And I wrote her a provider-to-provider letter. And I said, look, it's very rural here. It's beyond, fewer resources than you could possibly imagine. I can't have the subspecialty super-duper dermatologist write this referral. You're stuck with the family practice PA. Please consider that rural healthcare needs some attention from me with this one patient. And nope.
Wow, nothing, no feedback, nothing at all, nothing,
and
just no.
I think that for this particular really quirky problem that I happen to know something about, the local dermatologist, very bright guy, but was not helpful in this situation to her. And so I was advocating for her. But it's like they're absolutely not going to do it. And she has no resources to go to Reading, to another dermatologist. And they're going to be saying, sometimes it makes a difference, like with allergists. So we have a really great allergy practice, and especially good for kids in Humboldt County. But that particular physician works part-time. I think they might have a PA or a second physician now. But for a while there, her practice was so impacted that we had to be sending people to Reading and Medford.
Wow.
Maybe we should just call it Redford.
Redford, anyway. Just over the hill.
And those guys over there were super helpful for like a couple of months and then started complaining. But they test for different environmental things and those.
Yeah, right.
Those
An
areas
allergist is a specific sort of thing. Yeah.
Right. And she had a better grasp of what was here. So it, not only was the travel and the time delay, but it also expertise was important in that one.
Yeah. 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 And that way you really need a local allergist there who knows what to test for.
So what questions do you have?
So what is ultimately, we've been talking about, so we're talking about barriers to access to care. Am I understanding or refining the idea too finely or not well enough or whatever? It really doesn't seem like there are barriers to care. There just seems to be one barrier to care.
Yeah, it's money.
Right.
Yeah.
Wow.
Yeah.
I mean, we can parse it out and say, oh, it's rural. It's, lack of access to specialties and specialists here where we are because of where that all just boils down to. It all boils down to everything seems to with healthcare boil down to money when it comes to the system falling apart.
Right.
And a system built by people who live in more privileged situations in cities and with higher income. These systems are built by them to get your referral and to get your sick behind 80 miles to the doctor or whatever. All of these systems aren't built by the people who use them in the country, in the rural settings.
Oh, God, no.
And so they kind of look at you like, well, no, the system holds fine here in Los Angeles, Sacramento, San Francisco, Fresno, whatever, but not up here.
I had that exact scenario about a year ago. I had a patient who died of kind of an undiagnosed pulmonary, train wreck. It was awful. It was awful. And his daughter happened to work in LA for a pulmonologist, and she just didn't understand why we couldn't get him to a pulmonologist.
Wow.
And so his primary diagnosis was unknown. I mean, we could make just, fancy Latin word descriptors of what we saw, but the true understanding that we needed to make him better, or at least support him, or maybe get him to a lung transplant, and definitive care was gone.
Wow.
It was really sad. So people die because of this.
Mm-hmm.
But there's a light that maybe somebody can explain why it isn't used more often, but Medicare. I remember saying Medicare is like saying apples. There's a lot of different policies out there, and some are private and some are still public. But supposedly Medicare patients are allowed to self-refer. Okay. Right? You're making the surprise face.
That's even a possibility. You can do that?
Right.
I'll be damned.
Right. And
is that why, so Mike Thornton, who's been on Health Matters and was on KFUG for a while, a number of years, he would just glow when he finally got Medicare. He's like, oh my God, this is how it's supposed to be. Is that the kind of thing he's talking about? The ability to have that kind of freedom of access?
Right. Huh. So, but sometimes you can talk to a practice about referring somebody and say, hey, they got Medicare, so they should be able to self-refer. So I don't even have to be in the loop.
Wow.
I'm just going to give them your number, and you're going to set them up for an appointment. Mm-hmm. And then they make an artificial office rule. That's not really...
What, that they don't do that? We only take referrals.
We still need a referral.
Okay.
And I don't understand that.
Yeah, why would that be? Why would that be?
I think it's trying to control the flow of patients into a specialist that's maybe a little overwhelmed.
Yeah. I could see that.
There's a lot of kind of artificial rules to control flows of things that are not really good for the patients.
In that regard,
they're not justifiable.
Well, and with the specialist seems to be foisting off the maybe it shouldn't. The specialist shouldn't have the responsibility to triage patients like that, but they seem to be foisting that off on the people who should be writing the referrals.
And they also assume that family practice people. Now, remember, one of the reasons a lot of this is not an attractive community for a family practice physician to come up in is that they have to do way more than family practice. Mm-hmm. It's kind of like on YouTube. I listen to this particular doctor has a sense of humor and does little routines, and they talk about rural healthcare, and they talk about Texaco Mike, who made he's got a CT scanner that's mixed with an MRI machine in the back of his gas station. So, that's kind of the level of involvement that a family practice person, is going to need in this community, that they're going to need to think outside of the box. They're going to need to have multiple talents. They're going to need to be more than family practice in subspecialties. They're going to need to understand the community. So the language, part of the community is important. And I'm finding it's kind of an aside, but I'm finding with the travelers, I'm working with 2 traveling physicians right now at UHS, both lovely women, really dedicated to this community for the time that they're here.
Yeah.
But they don't understand these wacko rules, and that's got me focused on them right now. And so they come to me, how can I get this? This person really needs and I'm like, I don't know, maybe I can text Katie and see if she's gonna, and you do everything kind of based on who you know.
You Del Norte it.
And you Del Norte it, and you turn in like little chits for favors. You do a favor for somebody and then they owe you and you never forget it. So I would say if somebody out there is on Medicare and they want to go to a specialist, that they should just try and go directly. It's worth a phone call.
At least a
Because
phone,
I have
right?
seen it work about 50% of the time. That's the other thing I'm going to say. I think this has about a 15% chance of working, but that's not zero, so let's do it.
Yeah.
You know? But, it probably is office dependent. So.
My wife Lisa has kidney issues, just kind of chronic kidney issues her whole life, and is sort of tiptoeing the line with kidney disease, and so she's on top of it, and yearly or every couple of years is going in and checking up and making sure functions are fine. She had a big thing with a referral just this last time. She wanted a referral to a kidney doctor so that she could get past the PCP level to get to a specialist to get the real skinny on the information.
Totally makes sense.
And she's good. She can work wonders with her My Chart and just reading things. And she has caught things that people have dropped. The system has dropped and followed things up. And she could not get, and had a really, really bad conversation with this person who was really dismissive with her about no, you're not. No, why?
Was that her primary, or was that the referral?
The referral. It was the specialist. No, you don't need a referral. Why are you coming here? Why? It's like, really. And and she kept after it because she knows how the system works. And we talk about her health care all the time in context of what you and I discuss on health matters. And so she kept after it, found out the most recent scans and information that she'd gotten done at the PCP level hadn't gone with the referral to the specialist.
That also happens because the person collecting all that stuff, really nice, wonderful people, are not medically educated.
Is that level that we're talking?
Yes, that's exactly what I'm talking about.
Wow.
And they don't see the relevance, or they just don't get the refinements that are kind of inherent in it that any medical person would get.
Why would this information in this system be passed through like an ignorant sieve like that? I mean, I understand it's
more
for money.
Uneducated than ignorant, but yeah, because they are actually very educated in how stuff gets paid for.
Sure, but that shouldn't be. But they're making decisions not about how stuff gets paid for.
Yes, exactly. There's the nugget of today's discussion.
Wow. Oh my God.
Wow is right.
It just makes me so angry.
Yeah. It's also hard to find, I'll just say it's hard to find a nephrologist up here, by the way. So I think a little bit of that is gatekeeping. The nephrologist, the only one I can think of in 3 counties, actually.
Wow.
So.
Wow. We talk about what is I guess again we come back to what is the man woman on the exam room in the exam room supposed to do. You've got to be your own advocate. You've got to stay on top of this, and you've got to realize that there are people out there, it seems, the way you've described the system, who are actively trying to undermine your health.
They're making financial decisions. They're not making humanitarian decisions.
Right. Yeah.
So it's healthcare rider privilege. Here we are again.
Again, as always.
Yeah. But.
Wow. Okay. Well, that's depressing, and again, I think we got to the bottom of what's the real problem with rural healthcare, and it's the real problem as it ever was. It's money, and that money being the sphincter through which everything has to pass. It's just ridiculous. Okay. All right. So is there anything happening, anything uplifting we can talk about next week?
Dr. Reamer is going to talk to us about flu immunizations next week via telephone. He's a really, really charming physician who had he had some emails that I picked up on and some interesting insights, and I thought it was good. It would be good to have a different voice speaking. Because it's getting to be that time of year. It is.
And that can be an uplifting topic this time of year to talk about what needs to happen.
Yeah, he used to have a show similar to this on KHSU.
Really?
Yeah.
Oh, I did not know.
Terry Reamer. He's diabetic expert, but he's so passionate about preventative care medicine.
Oh, right on.
So.
Okay.
Yeah.
All right. Well, I look forward to that conversation. And as always, thank you again for this week's Health Matters, Lynn. We'll see you next week.
All right. Thanks.